So, good evening, everyone. Once again, my name is Joki Washira. I work for Equalize Health, and I'm excited to be here, and I'm also excited to see you here. You're all welcome to the fourth session of the Kogs tele-mentoring series on strengthening obstetric and gynecology care for maternity teams. So today's topic is on hypertensive disease during pregnancy. So I'm getting some feedback. So today's session is about hypertensive disease during pregnancy. Equalize Health has partnered with Kogs to bring this online training series for all of you. Since 2018, we have been implementing several telemonitoring programs for health professionals in India and in Africa. Our program works with the principle of the Project ECHO by the University of New Mexico. And to start us off, I would want to start with a bit of housekeeping announcements. And the first one being, kindly keep yourself muted unless talking, and keep your videos on if possible. Also feel free to respond to questions without any hesitation. This is a non-judgmental free zone, and every case discussion should be treated without any judgment, and any case should be treated as an example to learn and to share. So you can also post your questions in the chat box. And at this moment, I'd like to welcome Dr. Winnie to introduce the speaker for today. Karibu sana, Dr. Winnie.
Good evening, everyone. Thank you, Joki, for welcoming this session, and thank you everyone for joining in. This is our fourth session out of the 12 sessions that we are having for this series, and it's on hypertensive disease during pregnancy. Our expert for the evening is Dr. Tungani Muchiri. Dr. Tungani Muchiri is an obstetrician gynecologist at Marago Sub-County Hospital. He's also a faculty member at Kirinyaga University. Dr. Muchiri has completed his Bachelor of Medicine and Bachelor of Surgery, as well as his MMed in obstetrics and gynecology. He has vast experience working in the field of obstetrics and gynecology. He has several research papers published on early pregnancy, vaginal deliveries, and rhizomelia. So, karibu, Dr. Muchiri, please take over.
Thank you very much, Dr. Mwebia. I hope I am audible. Maybe Joki, you can answer me if I'm audible.
Yes, you are.
Yeah.
I can hear you clearly.
Thank you, thank you. So kindly feel free to raise any issues in the chat. Okay, I can see someone has said no sound. That is Anyango.
The sound, I think it's her system.
Okay, fair enough. Njoki, if there is any issues with the technical aspect, you will raise it to me. So today we are talking about hypertensive disorders of pregnancy, and this is a very wide topic, and trying to squeeze it into a 1-hour session might not do the justice that it deserves, but we shall try. And to start us off, probably I would like to share 1 or 2 cases so that we see the situation on the ground. And the first case is that of JN, primigravida. She presented at 37 weeks. This is a patient who had gone to a dispensary initially before she was referred to the level 4. And She had started feeling unwell the evening before. She said she was feeling dizzy. Then she started having a severe headache, which lasted overnight. And she waited until in the morning. This was during the curfew, so she could not find reliable transport to the facility. She had only attended one antenatal clinic at 26 weeks, where her blood pressure was high at 148/92. She was given some medication. She was supposed to return, but she did not return. Now, on the day of presentation, she arrived at 5 a.m. at the dispensary. By this time, she had also started developing low abdominal pains. She had vaginal bleeding, and the blood pressure was recorded at 172/112. And they were able to do a urinalysis, which showed proteinuria, 3+. And they decided to refer her to the higher facility. And due to the issues of referral and the ambulance and all that, she arrived 4 hours later. By this time, there was massive hemorrhage, and she was taken immediately to theater. A cesarean section was done, and a stillbirth was delivered. Postpartum hemorrhage was encountered, and despite all conservative measures and massive blood transfusion, they were not able to achieve hemostasis. So a subtotal hysterectomy was eventually done on the primary gravida, now para 1. And in the post-op period, she developed acute kidney injury, and this necessitated dialysis. That is one case. Another case, we had DWN, 39 years, para 4, all cesarean sections. So she has had 4 cesarean sections. And the reason she had come to the hospital is she had referred herself for family planning. But when she was seeking advice, she was found to be pregnant. She was initially on oral contraceptives, and this method was stopped when her blood pressure went high. But she did not have an alternative method for about 3 months. And now when she came, she was coming for an alternative method, but she was already pregnant. So she decided to keep the pregnancy anyway. This was her 5th. And now on follow-up, she was switched from her prior medication, which was Losat H, and it was switched to methyl dopa. She was also put on folic acid. At 12 weeks, she was started on aspirin. She had a fairly non-eventful pregnancy. Blood pressure was well controlled on medication. And at early term, she was delivered. She delivered a healthy baby via cesarean section. Tubal ligation was also done, and she was followed up in the hypertension clinic. So I wanted to bring up those 2 cases so that when we are discussing, we don't seem like we are discussing abstract things. These are things we encounter in daily practice. And we know how common hypertension is. Of all the medical conditions, I think it's the one that is encountered the most in pregnancy. And it accounts for quite a number of our maternal deaths, estimated at 10% in Africa. And it has been studied widely. There are very many study groups on the same and very many guidelines. So nobody can say they don't have information on the same. Now, there is an image there projected that shows the correct way to take the blood pressure. You can see how the patient is seated comfortably in a seat. The feet are lying on the floor. They are not hanging, and they are supported. The arm is supported. Then there are additional recommendations that have been made by the American Heart Association, that the room should be quiet and comfortable. The patient should not have smoked or taken coffee or done exercise at least half an hour before, an empty bladder, and they're supposed to relax at least 3 to 5 minutes after reaching the facility. And we should take ideally 3 measurements at a minute intervals. And the patient should not be talking. You should select the right cuff size, and the machine should be well calibrated. We used to say that only a mercury sphygmomanometer is accurate, but by and large, manufacturers are making better and better electronic machines to do the same. Now, when we say hypertension, we are talking of somebody with a systolic blood pressure of above, equal to or above 140 millimeters of mercury, or a diastolic blood pressure that is 90 or above millimeters of mercury. And a repeated examination is desired, usually recommended 4 to 6 hours. Now, when blood pressure goes to systolic of equal to or above 160 millimeters of mercury or 110 diastolic, now that becomes severe hypertension. And in such a case, you may not have to wait the 6 hours to repeat to confirm. You can repeat after 15 minutes. Now, in pregnancy, there are 4 main hypertensive disorders we encounter. This is chronic hypertension, gestational hypertension, preeclampsia, and chronic hypertension with superimposed preeclampsia. Now, there are other entities which are not well studied and whose significance is not very clear. We have white coat hypertension and so-called MAST hypertension. Now, to define this further, chronic hypertension is when high blood pressure had onset before the pregnancy or before 20 weeks gestation. We might be able to see later why we are talking of 20 weeks gestation. Now, gestational hypertension is when the hypertension has onset beyond 20 weeks without maternal organ dysfunction. Now, what we have come to know is that gestational hypertension carries a risk of developing into the next entity, which is preeclampsia. And preeclampsia has classically been defined as gestational hypertension that is accompanied by proteinuria. However, when there is maternal organ dysfunction, the so-called severe features of preeclampsia, we also classify that as preeclampsia, even if there is no proteinuria. Another feature that may accompany is uteroplacental dysfunction. Now, we may have features of growth restriction or oligohydramnios in the fetus. We have preeclampsia that can be superimposed on chronic hypertension. This is a patient who develops features of preeclampsia when they had chronic hypertension. That is, onset of the hypertension was pre-20 weeks, but later on they developed the 3 features of preeclampsia mentioned. There are other entities or sequelae of preeclampsia that we know of. We know of HELP syndrome, which is a disorder characterized by 3 things: hemolysis, an elevation of the liver enzymes, and thrombocytopenia or low platelets. We know of eclampsia. Now, eclampsia is said to be new onset seizures or coma in a patient with preeclampsia or gestational hypertension. And these seizures should not be attributable to another cause, like a space occupying lesion and such things. We did talk of white coat hypertension, which I will not dwell on a lot. And this is when the blood pressure is elevated in the office or clinic, but is consistently normal outside that setting. It's like the patient gets anxious in front of the health worker. There is another even less known entity called masked hypertension, where it's the opposite of the above. That is, the blood pressure is normal at the clinic, but it's elevated at other times. These are patients who may get the automated home BP measuring machines. And now when you look at the readings from home, they are higher than what you get. Significance is not very clear from studies. Then we did talk about severe features of preeclampsia. And what are these? When the blood pressure is in the severe ranges, that is a woman who has systolic blood pressure above 160, systolic or diastolic 110 or above. And this is measured 4 hours apart with the woman resting. When there is liver dysfunction, and these are mainly the transaminases when elevated more than double, or severe persistent upper quadrant or epigastric pain, not attributable to any other cause. Kidney dysfunction when the creatinine level is above 1.1 milligrams per deciliter, or a doubling of the creatinine concentration, or when there is no urine production, oliguria. Of course, cerebral visual disturbances in the setting of preeclampsia, that is a severe feature. Pulmonary edema, another manifestation. And thrombocytopenia, a platelet count of 100,000 or below. Now, these are the severe features you'll hear of preeclampsia. Now, we've talked about 20 weeks, 20 weeks, 20 weeks. Probably this may explain why we are talking about partly. Because if you look at that chart, it shows the average blood pressure changes in pregnancy. And you'll notice that in the first half of pregnancy, there is a dip in blood pressure. And this is believed to be caused by the vasodilation, the vasodilatory effects of pregnancy hormones. And this is usually compensated by an increase in the heart rate. You can see after the second trimester, the first half of pregnancy, the blood pressure starts to rise, almost reaching the pre-pregnancy levels by term. So what does that tell you? It tells you that if somebody has high blood pressure in the first trimester, if it's not so elevated, it might be within the normal ranges because blood pressure dips in the first half of pregnancy. And in brief, the hypertensive disorders in pregnancy include pre-existing hypertension, which we call chronic hypertension. And this is a maternal medical condition that is complicating pregnancy. Then we have the others, the gestational hypertension, preeclampsia, and the superimposed, which are believed to be placental disorders. So they are pregnancy conditions. And they are occurring after 20 weeks. So preeclampsia, what do we know? A lot is still theoretical, but the placenta has been studied extensively, including locally, and a few things have been found, and they have been believed to be the causative agents of this condition. And in brief, is that the fetal cells that is the trophoblastic cells, they are so-called trophoblastic cells, are supposed to invade the maternal blood vessels in the uterus. The reason they are doing that is they want to increase the lumen so that the maternal blood vessels deliver more blood to the placenta. If you look at the image on the slide there, on the extreme right, you will find a very widened blood vessel. This is what happens in normal pregnancy. The trophoblastic cells invade the spiral arteries all the way through the decidual, that is the first layer, through to the myometrium, that is the second layer. And that is the normal progression. It happens in two phases. The first phase is the the decidual layer, then the second phase is the myometrial layer. What you have in the middle is when the trophoblastic cells only invade the decidual layer. So the blood vessel does not widen as much as it should. And this is believed to be the starting point for preeclampsia. The third image is in the non-pregnant state. That is how a spiral artery looks. So in brief, we are saying there is abnormal placentation. Now, what does that lead to? Leads to poor perfusion of the placental tissue. So there is placenta hypoxia. Now, this leads to production of some angiogenic substances which invade the maternal vasculature, and they cause various changes to the blood vessels on the maternal side. And to illustrate with an image is that we get from the angiogenic factors produced, we get systemic vasoconstriction and endothelial dysfunction. What does that lead to? The blood vessels, the maternal blood vessels become leaky, such that substances fluid can leak from the vasculature, and that's how we start getting edema. The vasoconstriction will, of course, systemic vasoconstriction will also cause an elevation of the blood pressure. There will also be hypoperfusion of maternal organs. Now, this small problem can be attributed to all the other problems that occur with the preeclampsia, eclampsia, sequelae. So, in history taking, trying to move with the time, what do we elicit? Okay, from the CNS, you want to find out if there has been headache or any visual symptoms, blurring. Sometimes the patient may just complain of anxiety, irritability, or they may present with seizures. From the chest, they may have chest pain, shortness of breath, or dyspnea, especially if there is pulmonary edema. In rare cases, when we have either liver dysfunction or thrombocytopenia, they may have bleeding tendencies, bruising, petechia, or vaginal bleeding. When the liver is affected, we talk of right upper quadrant pain, nausea, or vomiting. They may also have a reduction in urine output or the color due to concentration. And of course, don't forget to ask about the fetal movements. Differential diagnoses are wide, and of course, it will depend on the presentation. However, for the high blood pressure, it can be secondary hypertension. secondary to pheochromocytoma, thyroid disease, coarctation, or all the other causes that may bring hypertension. It can also be errors with recording. That is, we showed the right way for blood pressure to be recorded. If you don't follow that, you can get very high readings, or if your machine is not calibrated well. Patients who come with proteinuria, remember that I know patients get a routine urinalysis, and sometimes you'll get proteinuria without high blood pressure. Remember that we can have benign causes of proteinuria in pregnancy. Extreme exercise is one of them, or sometimes UTI, anything in the urinary system, a kidney stone, UTIs, you may get proteinuria, or it may be contamination from even blood. Acute fatty liver of pregnancy presents almost like preeclampsia. It can come also with proteinuria. Underlying kidney disease, of course, nephrotic syndrome, nephritic syndrome, autoimmune disorders also. Differentials that may come for convulsions include epilepsy, other organic causes of convulsions like infections, malaria, meningitis, toxicities, that is alcohol, poison, hypo or hyperglycemia, trauma, space occupying lesions, and many other causes. The differentials can be very wide because this is a systemic disease, meaning any organ can be affected. Now, investigations, mainly you are looking for end organ damage. In your hemogram, you're mainly looking at hemoglobin, which may be low in case of hemolysis. Platelets may get thrombocytopenia. Urine assessment for proteins. Now, I know routinely we do urinalysis, but the best would be to do a 24-hour quantification. You also do your renal function tests, looking at your creatinine, urea. Then the liver function tests, mainly the transaminases, and in cases of hemolysis, also look at bilirubin. Now, fetal assessment, apart from auscultation, it's always good to do an ultrasound. If you're able to do an unstressed test, is also advisable. Now, other tests that may aid in management include coagulation tests, of course, blood sugar, lactic dehydrogenase may be an indicator of hemolysis, uric acid, and there are other tests not routinely done in our setups like the placental growth factor, which can be used as a predictor of women to develop preeclampsia from chronic hypertension. Management, we do have goals, and your first goal would be to protect the mother. So to prevent severe maternal complications. These include cerebrovascular adverse events like seizures and stroke, organ damage, the kidneys, and the likes, and of course to prevent her death, because we know this disorder can also kill. Remember also there is a fetus, so once the mother is safe, look at the safety of the fetus. So you are aiming to prevent abruptio, growth restriction, and the death of the fetus. Then from there on, you want to make the mother comfortable, so symptomatic support. Now, with this in mind, how do you go about it? And the first step is blood pressure control. And like we say, prevention is always better than treatment. So if you're able to prevent these hypertensive disorders in pregnancy, start there. And We'll look a bit more on prevention. Treatment, of course, is using antihypertensives. We'll look at that also. Remember that these women with these disorders can't get eclampsia, so seizure control is also indicated. We'll look at how it's done with magnesium sulfate. And with these women, they should always have a plan for delivery. For the gestational conditions, that is gestational hypertension and preeclampsia, eclampsia syndromes, delivery is the treatment. So when to do it should always be in your mind. And of course, after that, we know that there is long-term sequelae of these conditions, so a follow-up plan is necessary. All right, now we have very many antihypertensives and many more are still being made as we do this talk. However, we have very few that don't cross the placenta. In fact, in my reading, I have not come across one that does not cross the placenta. And the antihypertensives that have been well studied are even fewer. So you'll find that in pregnancy, we have a very limited choice. It's probably limited because of information, because if we don't have information about a drug, we rarely use it. So what I've put there as safe is quite relative. I mean that these are the ones that we have good information on, and so are in current use. And one of them is Labetalon, which is a beta blocker with also alpha blockade too. It can be used as a continuation medication. It can also be used in the acute phase, in acute lowering of blood pressure in severe hypertension. It has a wide therapeutic range. If you look at the dosage of anything between 100 to 1200 milligrams per day, and it is contraindicated in asthma because of the risk of bronchospasms. Then we have nifedipine, which is a calcium channel blocker. Dosage sometimes goes up to 120 milligrams per day, but you'll find commonly we are used to the 40 milligrams per day divided in 2 doses. Used with caution in aortic stenosis. Then methyl-dopa is a centrally acting alpha-2 adrenergic agonist. It acts centrally. Therapeutic range goes anything between 250 milligrams, which is the tablet that is locally available, all the way to up to 3 grams, but recommended not to go above 2 grams per day in, of course, divided doses. Now, methyl-dopa in the postpartum period has been discouraged by some organizations because of the risk of depression. It also has some mild sedating effects. We have hydralazine, also a vasodilator, peripheral vasodilator. Comes as an oral or parenteral formulation, more commonly used in the acute setting to lower blood pressure when in severe hypertension. Now, the risk with hydralazine is that it can act very rapidly. It can have a very unpredictable lowering of blood pressure to the point of hypotension. And this can predispose to abruptio. So it's used with a lot of caution. Of these medications, the ones that can be used in the acute setup is labetalol and hydralazine. Nifedipine can also be used. Now, of course, we have the other antihypertensives that are widely available, used. Some are not safe. And we talked about Labetalon. Top on the list are ACE inhibitors, the likes of enalapril, captopril. Then we have angiotensin receptor blockers, the likes of losartan. And these ones are associated with renal hypoperfusion in the fetus, which can lead to renal dysgenesis. And of course, when that happens, the fetus is not able to make urine, and that will lead to oligohydramnios. There are other sequelae associated with these ACE inhibitors and ARBs, but this is the most commonly found anomaly. Diuretics have been used in pregnancy, but they are not recommended. When they are used is in the setup of volume overload. For example, if you're dealing with renal disease or congestive cardiac failure. The thing with diuretics is that they may worsen intravascular volume depletion. Remember, the hypertension of preeclampsia is mainly coming from vasoconstriction, is not from volume overload. So theoretically, if you were to deplete the volume further with diuretics, you may hypoperfuse the placenta. So diuretics are not very encouraged, and diuretics we are talking about the likes of hydrochlorothiazide, you're talking about Lasix, and so on. So their contraindication is not absolute, but they should be used with caution. We have beta blockers, and there is other beta blockers that is apart from Labetalon, and there is a worry that they can cause neonatal hyperglycemia and bradycardia. We have one of the common beta blockers is propranolol. It is used sometimes in pregnancy. The issue with propranolol is the risk of uterine irritability because of the beta blockade. Remember, beta agonists are used as tocolytics. Now we have magnesium sulfate. It is a drug that has saved lives, if I was to say so. And it is recommended as the treatment for seizures. The aim with magnesium sulfate is not to prevent an ongoing or to stop an ongoing seizure, because that seizure is likely to stop in the next few minutes. But you give it to prevent another convulsion. So it can be used as a treatment in eclampsia. It can also be used for prophylaxis against convulsions when we have severe features of preeclampsia. Now, some people have even just given it in preeclampsia. However, that is weighed against the toxicity and the cost to the system when you give all the women with preeclampsia. So the recommendation from WHO is it should be given in women with severe features of preeclampsia. Magnesium sulfate is also indicated for neuroprotection. That is to prevent adverse cerebral events in the newborn. It can also be used as a tocolytic in preterm labor. So it has quite a number of indications. Now the dose that we give for convulsions is that we load, and 4 to 6 grams have been used depending on who is the setup. and this is given over 15 minutes. Then after that, the recommended dose is 1 gram per hour for 24 hours. And you can give a further 2 to 4 grams if there are recurrent fits. Now, this may not be the formulation that we have. So Ministry of Health has given a different guideline where we are supposed to load with 4 grams of IV 20% over 5 minutes. This is the same as giving IM 10 grams, 5 on each buttocks, of course, with the lignocaine. We know that magnesium sulfate depresses the central nervous system. So we need to monitor the respiratory rate, patellar reflexes, and urine output. And in cases where there is renal failure, then are the best way to monitor for toxicity. There are some adverse effects. Top on that list is depression of the respiratory system and central nervous system. It can also potentiate hypotension, especially when given with calcium channel blockers, which can lead to circulatory collapse. Contraindication, mainly myasthenia gravis is the biggest contraindication. In patients with renal failure, it is advisable not to be given unless you can monitor the plasma levels. Now, antidote, you should always have calcium gluconate in your unit. You should be able to give a gram of calcium gluconate when you suspect toxicity, magnesium sulfate toxicity. Now, there are situations where you cannot give magnesium sulfate, like mentioned in those contraindications. In this, it may have options of phenytoin and diazepam. Now, in a very large study that was done called the MAGPI study, these was found to be not so effective, not as effective in seizure prophylaxis. And they came, of course, with the risk of respiratory depression, especially diazepam. So they are given as a last resort. Okay. Now, follow-up of these women in the prenatal period. You need to ask the mother always about fetal movements and to advise her that she needs to feel the fetal movements all the time, auscultation, and if you're able to do an unstressed test, and an ultrasound is also important. Now you'll notice that I've put a star on this slide. This is because there is no one size fits all, and every mother will have follow-up depending on her condition. These are recommendations, but you need to contextualize follow-up. Of course, for the mother, you need to ask for symptoms and signs of organ dysfunction, urine output, and to look at her lab works. Timing of delivery, again, you'll find that I've put a star. There are recommendations on when to deliver, but things on the ground are different. And generally what is like a consensus is that when you get to 37 weeks, the risk of keeping that pregnancy outweigh the benefits. So you need to ask yourself, how good is your monitoring and how reliable are your tests, your ultrasound, in telling you that this fetus is okay. So you'll find that most clinicians will deliver at 37 weeks when 37 weeks are completed, especially for preeclampsia. Now, when you have preeclampsia and you're not able to control either the blood pressure or the maternal organs are being affected on a daily, or there is a fetal indication for delivery. For example, you find the fetal status is non-reassuring, then you should make a plan for delivery as soon as possible. You may be allowed time to give steroids or magnesium sulfate for neuroprotection when you are below 34 weeks. But at 34 weeks onwards, most guidelines will agree that delivery is the best option. For eclampsia, you make a plan to deliver immediately. In the postpartum period, you review the medication. Usually blood pressure will stabilize after delivery on 48 to 72 hours. And because you have delivered, you expect the gestational conditions, preeclampsia and gestational hypertension, to improve. So you may be justified to review the medication at 48 hours or at 2 weeks. For chronic hypertension, you may want to revert to what the patient was on pre-pregnancy, and you give her a follow-up with a physician, either at 2 weeks or at the 6th week postpartum. We know these complications. We had mentioned some in the opening slide in the cases that we presented. One of them is growth restriction, placental abruption, and now people are finding that these fetus may have long-term sequelae that we have not been able to study. Like Walker et al. Had talked of autism and so on. Now we have maternal complications. Of course, eclampsia is top on that list, acute kidney injury, coagulopathies. And these women are at a higher risk of future cardiovascular disease. And studies are still ongoing on what we have previously not looked at. Stroke, especially when systolic blood pressure is very high, and of course, death as a complication. Prevention of either hypertensive disorders in pregnancy. The most important thing is preconception care. A woman with a medical condition should plan her pregnancies. She should not be surprised by pregnancy. And in so doing, she's able to avoid things that can exacerbate hypertension, like combined oral contraceptives, some antidepressants, non-steroidal anti-inflammatory drugs, and alcohol and steroids, long-term use of steroids and heavy alcohol use also associated with exacerbation of hypertension. Exercise, of course, is recommended as a way to combat many lifestyle diseases, not just hypertension. And there are recommendations which I might not be able to go into. And it is good to note that exercise is still safe in pregnancy. If a woman was exercising pre-pregnancy, she can just scale down, but she can continue to exercise in pregnancy. Then in pregnancy, what do you want to do? We say that preeclampsia is a placental condition associated with hypoperfusion. Now, aspirin has been found to improve this. And since it's not well studied in the first trimester, then it's recommended that we start it in the second trimester, which almost coincides with the second wave of trophoblastic invasion of the spiral arteries. Calcium supplementation where intake is low is also recommended, and these are basically WHO recommended preventive measures. And who are these women you want to give low dose aspirin? This is low dose. I'm talking about a dose of 75 to 150 milligrams. This is a woman with previous hypertension in pregnancy or pre-existing hypertension, renal disease, or diabetes mellitus. A woman with autoimmune diseases like systemic lupus erythematosus or antiphospholipid antibody syndrome. Women with multiple pregnancy, obesity, and for some reason, IVF pregnancies are associated with a higher risk of developing preeclampsia. What is common with these conditions, if you look at them, is either they are perfusion, hypoperfusion conditions, or they are conditions that increase placental mass without increasing perfusion of the placenta, which we found was the main pathophysiology of preeclampsia. Now, there are other areas where in my research, I did not find a lot of information, or the discussions are still ongoing. One is on the efficacy of these regimens in prevention of preeclampsia. That is vitamin D, antioxidants, vitamin E, vitamin C, omega fats. There's a molecule called L-arginine, which is also coming up. Statins, and mainly we are talking about pravastatin, have also been studied, though they have not been shown to be efficacious. And there are some small studies looking at metformin, and the theoretic basis is that it can improve angiogenesis and perfusion. Then there are some people who are looking at the effect of altitude on preeclampsia. Currently, it's also been found that there are long-term outcomes which we don't look at. For example, the cardiovascular risks to the mother, or the fetal outcomes that go beyond, just the delivery phase, like 5-10 years. How are these fetuses born to mothers who had severe preeclampsia? Then, of course, there are risk predictions studies going on, like are there molecules that we can measure in the blood and predict who will get preeclampsia and who might not. Doppler studies, how predictive are uterine artery, for example, or ophthalmic artery studies. Or, for example, can we predict using the demographics, like if we took the age, the race, and so on. These are interesting areas to look at on research. And finally, maybe just to sum up what I've been talking about. And the first thing is that this is a very common complication of pregnancy. It's the most common medical complication. And we know that there are many adverse outcomes that can come from this disorder. And we have seen that preconception care and prenatal care can lower the risk of getting preeclampsia in women at risk. And we are talking of prenatal aspirin and calcium supplementation when low. We have seen that some antihypertensives are unsafe in pregnancy. We have seen the importance of magnesium sulfate in prophylaxis against severe preeclampsia. And it has now become clear that women who get hypertensive disorders in pregnancy have an increased risk of cardiovascular disease later in life. Now, the recommendation would be that each facility to localize recommendations and to have their own guidelines on management of these conditions based on your resources and your capacity. Now, before we finish this session, because I know we have healthcare managers in this session, and those who are not are on their way to becoming healthcare managers, I want us to look at these two cases from a managerial point of view, and just look at which gaps, which low-lying fruits could have been, which steps could have been taken from a healthcare policy point of view that could have prevented these outcomes. For example, in case 2, this is a woman who was on a contraceptive method, then it was stopped. She was not given an option. Then she comes 3 months later. Then we have the previous case, a woman who came for one antenatal visit, and then she brought all these healthcare costs to the system. Maybe somebody can, say some intervention.
They can type the answer for about 30 seconds, and we read out the answers. They can type the answers in the chat. Yeah.
All right.
Maybe you could repeat the question. Kulikuwa na wengine tumelala.
The question is, we have case 1, a primigravida who only came with one ANC visit to her records, and then she had just this horrible sequelae of events that was a huge cost to the system. What are there measures we could have done that are low cost, that could have prevented all this? Yes, I can see Judith. Yes, better follow up. Counseling of mothers. From Nasra, we are saying counseling of mothers. Prenatal care, yes. Dispensary to be equipped with medicines like magnesium sulfate, yes. Health education on antenatal attendance, yes. Early referral, yes. Sorry, the answers are coming in fast and moving. And we can see delays in referral setups. The training of healthcare workers. This is very good because I can see people are also, apart from the treatment aspect, we are also thinking about the prevention aspect, which saves us a lot of costs. Perhaps we can think about the second case. Were there low-cost measures that could have just been taken and prevented all these issues that came up for the mother? Yes, I'm saying health education. Strengthening referral systems. Focused antenatal care. Use of condoms as a family planning method. Very good. Sometimes we forget that family planning advice is part of preconception care. PTL at the 4th CS, probably that was as per her choice. Very good. I've seen somebody offered to offer her IUCD as a method. Very good. Perhaps, Dr. Kigondo, I can pass the floor to you. You see the answers are coming in.
Yeah, thank you very much. As you can see, we have the topic has been very interesting, and we have a lot of people who are following. And as you can see, as a result of that, the answers are coming in thick and thin. I will quickly go through some of the questions that have come in, and just for an overview, so that we can summarize the points, and then because we like sticking to usually our 1 hour, which we have just covered, we'll do 10 minutes of that. A quick overview of the pathophysiology was what Kevin and someone else wanted. I think you can summarize it from the top of the head. Pathology.
All right. So we said that in a normal pregnancy, the spiral arteries, that is, these are the terminal arteries of the uterine artery. That is the blood supply from the mother. So these spiral arteries supply the placenta with nutrients. They come into contact with the placenta, and that's where the exchange of nutrients happen. Now, in a normal uterus, these spiral arteries are not they don't have a very wide lumen, and they are very muscular. So they just supply little blood supply. Now, when pregnancy occurs and the placenta attaches to the endometrium, now the fetal cells, the trophoblastic cells, they start migrating towards the spiral arteries. The reason they are migrating is they want to modify them to increase the size of their lumen and to make them very low resistance. That is, they widen and supply a lot of blood. Now, this happens in 2 phases. The first phase is up to the endometrium. The second phase is up to the myometrium, the inner layer of the uterus. Now, normally the first phase happens organically without much problems. The second phase is the one that does not happen in preeclampsia. So what happens is that in a normal pregnancy, the spiral arteries widen and supply nutrients very well. But in preeclampsia, they don't widen as such. So there is less supply to the placenta. And this makes the placenta hypoxic. And when it's hypoxic, it starts producing other substances, the so-called VEGF and so on and so forth. Now, these substances go to the maternal circulation and they start affecting the blood vessels of the mother. And one of the things it causes is that it makes them very leaky, and it also makes them vasoconstrict. Now, those 2 changes account for majority of the effects that follow in preeclampsia. Okay.
That's excellent. So Elijah Mungadia asked, what's your comment on the use of nifedipine, looking at its side effect in a mother who would still be having headache?
Yes. Now, one of the side effects of nifedipine long-term use is headache. Another one is, of course, edema. So what is advised with any hypertensive medication? When there are side effects, substitute it. If you're not able to substitute it, lower the dose and put an extra agent so that you get less side effects, but the same effect. So you can add another agent and lower the dose, or you can stop it and substitute it with something else.
Judith Elavian asks whether Labetalol causes fetal bradycardia postpartum.
Now, it is postulated that a lot of these beta blockers can have that effect. Of the beta blockers, Labetalol is the one with the better profile of all of them. Not much information in the postpartum period as opposed to the postpartum and prenatal period.
Mary Nafula asks, it is well received to say that magnesium sulfate loading dose is 14 grams, 4 grams IV in 20% concentration, then followed by 5 grams, 50% on each buttock.
Yes. Perhaps the confusion is that because magnesium sulfate comes either in 20% or 50%. So the 4 grams that you're giving IV is the one that is 20%, of which if you have 50%, you give IM, or you reconstitute it to 20% using normal saline or water for injection.
How much magnesium sulfate should one give for neuroprotection? Francis Mungai asked.
Dose is not pegged, but the same dose you give for magnesium for seizure prophylaxis is what most setups will use.
What's the minimum time given between administration of steroids and delivery of for preeclampsia with severe features?
This is quite a good question. And I think one of the local studies done recently by a classmate showed that even when you give it 12 to 24 hours, that there is still some benefit. So I may not be very strict because data is not available, but 24 hours is reasonable.
What happens if a mother is allergic to sulfur but has signs of preeclampsia? Do you give magnesium sulfate?
Because of the sulfur component. I have not come that as a contraindication, but I will not comment. Probably I can answer that in the chat.
Clarification needed. Does ketamine cause hypertensive crisis and should be avoided in case of CS? Secondly, agometrine, 2, are they contraindicated? In case of PPH and no tamponade balloon, how do you solve hemorrhage in the event of oxytocin not being efficient?
Okay. So we know that the 2 drugs are contraindicated in the setting of hypertension. Now, what alternatives to have probably goes the scope of our topic today, but for igometrin, probably these days we have misoprostol, we have carbetocin. So that could be an option, but do not use it in the setup of hypertension.
Another good question. If a mother who had previous preeclampsia, what is your take when she asks about future pregnancies? How long will she take for subsequent pregnancies?
It is dependent on her blood pressure control. We know that generally a short interpregnancy interval is not good. That is anything less than 18 months. So she should not have that. Secondly, if her blood pressure is not well controlled in the interpregnancy interval, then she should have a blood pressure well controlled before she gets pregnancy.
How do you manage a client who delivered, then after a few hours, she presents with high BP, proteinuria, and convulsions?
I think definitely you manage it as eclampsia, and the outlined management would be, after your investigations and assessment, is to start seizure prophylaxis and to control the blood pressure, because postpartum eclampsia is an entity that we know of, and it should not be ignored. Management is the same as prenatal. It's only that this time the fetus is out.
Yeah, 2 aspirin questions. How long do you continue with aspirin, and at what gestation do you discontinue aspirin?
When to discontinue is controversial. Some recommendations say up to 36 weeks. Others have said up to delivery. The risk here is the risk of hemorrhage postpartum, because aspirin is a blood thinner. But it is reasonable to go up to 36 weeks as you anticipate delivery.
There is George wants to know about resistive index, mid-cerebral artery as indicators of severity of preeclampsia. That is cutoffs and indications for delivery using the same.
Okay. Now, perhaps just to explain to those who may not follow, the resistive index, you are looking at, when you're looking at either the umbilical or the middle cerebral artery, the umbilical, you are looking at perfusion, the perfusion of the placenta. So it is an indicator. The cutoff values depend with the gestation, but up to in the third trimester, we talk of maybe anything below 0.7 being okay. Above 0.7, now you're going in the danger zone. And now when you're going to the values of 1 and above, now perfusion is not happening in that placenta, and delivery should be imminent. People are now even talking more of the pulsatility index versus the resistive index. So I would say it's in the context. You may not use it as the only indicator of when to deliver. It is the whole patient condition.
Another good question for gestational hypertension, more specifically high BPs coming 2 to 3 days before delivery. Do you still continue with methyl dopa for 2 days after delivery, or do you just stop the medicines and monitor BPs after delivery?
It depends on if it's purely gestational hypertension and it came 48 hours to delivery, this is likely to be a transient event. And if it was not severe, you are justified to stop the medication because you assume now that you've delivered the placenta, it will resolve. So you can stop the medication and monitor the blood pressure. And if it remains within the normal ranges, then you discontinue the medication.
Very good. I think we have come to the end of the questions. I think the presentation was very engaging. and very educative. As had been earlier proposed, the link to the presentation will be sent to your email addresses. And next Monday and Wednesday, again, the series will continue, and you are asked to log in as you have done today. And I think with that, we can call it a day because we like to keep it short and sweet. Thank you very much, Dr. We will see everyone next week.